Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing to it as well as share it to your near and dears to help them in their preparation of MBBS course as well as other postgraduate and job entrance examinations. Also, please don't forget to press the bell icon below so that you never miss an update from us. The last lecture was part 2 of breast cancer. This lecture is the last part, the part 3 on breast cancer. Next lecture topic will be the leg calf perthes disease. This is a very hot topic for both board and competitive examinations. Hope you will not miss it. Adjuvant therapy in cancer treatment is given after primary treatments such as surgery. It may be either radiotherapy or chemotherapy. Adjuvant radiotherapy is an integral part of breast cancer treatment protocol in most breast cancer patients with an intent to cure the disease. After conservative surgery for an infiltrating carcinoma, radiotherapy must be performed regardless of the characteristics of the disease because it decreases the rate of local recurrence and by this way morbidity and mortality. Radiotherapy is recommended after breast conserving therapy or lumpectomy to reduce the risk of cancer recurrence in the breast and nearby lymph nodes. After mastectomy, especially if the cancer was large, a spread to many lymph nodes or the resection margins are positive. If the cancer has spread to other parts of the body, such as bones, spinal cord, or brain. After neoadjuvant chemotherapy and before surgery to downstage the disease, and after adjuvant chemotherapy following the surgery. For ductal carcinoma in situ, adjuvant radiotherapy must also be performed after lumpectomy. In patients with T1N0 or T2N0 breast cancer, mastectomy and a sentinel lymph node dissection provide effective local control and radiotherapy is not required. But after mastectomy, chest wall irradiation is required for PT3, T4 tumors and if there is an axillary nodal involvement, whatever the number of involved lymph nodes may be. However, the use of post-mastectomy radiation therapy for patients with stage 2 disease is controversial. Axillary irradiation is recommended only if there is no axillary surgical dissection and there is a positive sentinel lymph node. Post-operative chest wall radiotherapy improves survival in women with node-positive breast cancer. Breast conserving surgery is often followed by radiotherapy to the remaining breast tissue because recurrence rates are too high if only local excision is done. 3D conformal irradiation is the recommended radiotherapy technique. Respiratory gating could be useful to decrease the cardiac dose. Concomitant administration of chemotherapy is not advisable, but hormonal treatment could be started with or after radiotherapy. Side effects of radiotherapy are skin changes, fatigue, hair loss, nausea, vomiting, diarrhea, urinary problems, and breast pain. For women who do not have estrogen or progesterone receptor positive disease, hormone therapy is not worthwhile. The understanding of the biological nature of carcinoma of the breast has revolutionized the breast cancer treatment over the last 25 years. It is now clear that the extent of micrometastatic disease at the time of diagnosis is the main factor that determines the outcome of breast cancer treatment. Loco-regional surgical or radiation therapy may influence the local relapse but does not handle the distant micrometastatic disease. Hence, it does not alter the long-term mortality from the disease. It is the systemic therapy targeted at these distant micrometastases that might be able to delay the relapse and prolong survival. Many international clinical trials have shown that the appropriate use of adjuvant chemotherapy or hormone therapy may result in an absolute improvement in survival rates up to 10% at 15 years. The adjuvant systemic therapy is a treatment given after primary surgery to reduce the risk of recurrence by targeting and eliminating any remaining distant cancer cells away from the primary tumor site. Adjuvant systemic therapy may be in the form of cytotoxic chemotherapy or hormone therapy or targeted therapy or immunotherapy. Lymph node positive and many high risk node negative women should be offered adjuvant combined chemotherapy. At least 5 years of endocrine therapy with 20 mg daily of tamoxifen or with aromatase inhibitors like anastrozole, exemestane, and letrozole is recommended for premenopausal or postmenopausal women respectively who have hormone receptor positive cancers. For women with a stage 4 breast cancer, systemic therapy is given to palliate symptoms from cancer and potentially prolong survival. For women with metastatic breast cancer, achieving overall survival is the gold standard aim, while disease free survival is a valuable endpoint. The studies have shown that short disease free intervals is associated with better overall survival. Treatment strategies like chemotherapy, hormone therapy, and targeted therapy can improve both disease free survival and overall survival. Most breast cancers express estrogen receptor or progesterone receptor or both. Interrupting the production of estrogen or blocking the effects of estrogen and progesterone at the receptor level results in improved disease free survival and overall survival in women with metastatic breast cancer. Hormone therapy works by either reducing the amount of hormones in the body or by blocking them from attaching to the cancer cells. In breast cancer, hormone therapy may be done in three ways. By using selective estrogen receptor modulator drugs like tamoxifen that block estrogen from binding to receptors on the breast cancer cells in premenopausal women. By using aromatase inhibitor drugs that reduce the production of estrogen in body, particularly in postmenopausal women. And by ovarian suppression through LHRH agonists or oophorectomy, which can also reduce circulating estrogen levels. The 5-year tamoxifen therapy is the most widely used hormonal treatment for breast cancer in premenopausal as well as postmenopausal women. If the patient is still premenopausal after 5 years of treatment, she may be offered an additional 5 years of tamoxifen therapy. This approach has resulted in reduction in the annual recurrence rate to 25% and annual death rate by 17%. Tamoxifen is generally well tolerated. Its most common side effect is hot flashes or vasomotor symptoms. Rare side effects include increased risk of thromboembolic events and endometrial cancer. It is equally beneficial for patients with lymph node positive and lymph node negative disease. The oral aromatase inhibitors like anastrozole, exemestane, and letrozole are used in postmenopausal women. These are used for treatment of all stages of breast cancer and are superior to tamoxifen. There is an additional benefit of reduction in occurrence of disease in the contralateral breast. The recommended duration of treatment with selective aromatase inhibitors is a minimum of 5 years, either as primary therapy or after 2-3 years of tamoxifen therapy. The most common adverse effect of aromatase inhibitors is osteopenia or osteoporosis. Uncommon but important side effects are hot flashes, arthralgias, myalgias, and vaginal dryness. Aromatase inhibitors inhibit the aromatase enzyme and block the conversion of the hormone androstenedione into estrone. This enzyme is present in breast tissue, breast tumor cells, as well as in other sites. Ovarian ablation or suppression also reduces the risk of relapse and death from breast cancer. If the patient has high risk disease, then ovarian suppression should be offered in addition to hormonal suppression. Chemotherapy is usually administered in cycles with periods of treatment followed by drug intervals to allow the body to recover from side effects. The chemotherapy is traditionally and most commonly administered as adjuvant therapy after completion of the primary surgery. But a neoadjuvant approach results in a significant reduction in tumor size and converts inoperable tumors to operable ones, and also makes such tumors that would require mastectomy amenable to lumpectomy. Larger tumors shrink to allow an improved cosmetic outcome with breast conserving surgery. Other potential advantages of using chemotherapy before surgery may include the reduction in the volume of microscopic metastatic disease, decreased drug resistance by treating tumors before resistance has developed, and increased efficacy of treatment. Neoadjuvant chemotherapy eradicates microscopic disease in the regional nodes in 40% of patients, reducing the need for complete axillary clearance at the time of primary surgery. Neoadjuvant or preoperative chemotherapy is offered to premenopausal as well as postmenopausal women with a poor prognosis, large but operable tumors that would traditionally require a mastectomy. It may also be considered in poor prognosis, node negative patients if there is a high risk of recurrence. Neoadjuvant therapy is also used in triple negative patients, that is, ER, PR, and HER2 negative patients. Metallic clips are placed in the tumor mass before neoadjuvant chemotherapy. These clips serve as a visual marker, allowing the surgeon to precisely identify the tumor bed because, in response to chemotherapy, the tumor may shrink or become non palpable, making it difficult to locate during surgery. The chemotherapy should be started before hormone therapy to reduce side effects. High dose chemotherapy with the stem cell rescue for patients with extensive lymph node involvement offers no advantage and has been abandoned. Cytotoxic chemotherapy for metastatic breast cancer initially consisted of single agent regimens, but currently combination therapy is considered from the start because of their high response rate and early onset of clinical benefits. Chemotherapy using a first generation regimen such as 6 monthly cycles of cyclophosphamide, methotrexate, and 5-fluorouracil, that is CMF regimen, achieved a 25% reduction in the risk of relapse over a 10 to 15-year period, but the toxicity associated with CMF regimen negatively impacted the gains in survival rates. Therefore, CMF regimen is no longer recommended. Currently used second and third generation regimens include an anthracycline such as doxorubicin or epirubicin, and the newer agents such as the taxanes like docetaxel and paclitaxel. The anthracyclines are topoisomerase II inhibitors and act as antimetabolites. They have high levels of activity against breast cancer cells. Taxanes are microtubule inhibitors. They are effective against anthracycline resistant tumors also. Chemotherapy is generally administered with combinations of medications with a view of using different mechanisms of action in targeting tumor cells and taking advantage of non-overlapping toxic effects. Combination which is being increasingly common is to combine a cytotoxic chemotherapeutic agent with a targeted agent other than hormone therapy. The targeted agents such as a CDK inhibitor or an anthracycline or a taxane often have very low response rates when given as monotherapy, but they provide added benefit when given in combination with cytotoxic drugs. Human epidermal growth factor receptor 2 or HER2 is a protein that plays a role in cell growth and division. Normally, there are two copies of this gene. In about 20 to 25% of breast cancers, the HER2 gene is amplified, means there are extra copies of the gene, leading to more HER2 protein production. The overproduction of HER2 protein results in aggressive tumor growth and spread, making it a key target for targeted therapies like Herceptin or trastuzumab. HER2 status is determined through tests like immunohistochemistry and fluorescence in situ hybridization, which assess the level of HER2 protein and the number of HER2 gene copies, respectively. HER2 targeted therapy with newer biological agents can significantly improve survival and outcomes for patients with HER2 positive breast cancer. Examples of these newer biological agents are the growth factor receptor CRB2 inhibitor trastuzumab or Herceptin and an oral combined tyrosine kinase inhibitor TKI lapitinib and pertuzumab. Trastuzumab or Herceptin is a humanized recombinant monoclonal antibody that binds to the extracellular domain of HER2 receptor. It selectively exerts anti-tumor effects in patients with HER2 amplified breast cancer. Trastuzumab combined with chemotherapy is even more effective than its monotherapy. Another drug used in HER2 positive disease is TDM1. It helps chemotherapy agent imestane to kill HER2 positive cells just like trastuzumab or Herceptin. Additional combinations of drugs targeting HER2 receptor are being developed. The trastuzumab-pertuzumab combination is approved in all disease settings. The triple-negative breast cancer is an aggressive type of breast cancer where the cancer cells lack estrogen and progesterone receptors and do not overproduce the HER2 protein. Means these are ER negative, PR negative, and HER2 negative breast cancers. These are different from other ductal breast cancers because these may express molecular markers found in basal or myoepithelial cells of mammary ducts. BRCA1 but not BRCA2 mutations are thought to be a risk factor for the development of these breast cancers. The triple negative breast cancer is very aggressive in nature and tends to grow and spread faster than other types of breast cancer. Triple negative breast cancer accounts for about 10 to 20% of all breast cancers. Because the cancer cells lack hormone receptors as well as any excess HER2 protein, hormone therapy and HER2 targeted therapies are not effective against triple negative breast cancers. Chemotherapy is often the primary systemic treatment option for these triple negative breast cancers. Triple negative breast cancer also tends to recur more frequently than other types of breast cancers. Breast cancer occurring in the male mammary glands accounts for less than 0.5% of all cases of breast cancer. The most common type is an invasive ductal carcinoma. Risk factors for male breast cancer include advanced age, family history of breast cancer, BRCA1 and BRCA2 genetic mutations, Klinefelter syndrome, excess estrogen exposure, obesity, cirrhosis of liver, and radiation therapy to the chest. Notably, gynecomastia is not a risk factor. Male breast cancer also presents as a lump like a female breast cancer. Most, that is 80% of breast cancers are ER positive, 75% are PR positive, and 35% are HER2 positive. Because there are no terminal lobules in the normal male breast, invasive and in situ lobular carcinoma is rarely seen. Prognostic factors for male breast cancer are the same as those for female breast cancer, including lymph node involvement, tumor size, histological grade, and receptor status. The treatment is same as that of carcinoma in a female breast. A small tumors may be treated by local excision and irradiation or by mastectomy. Adjuvant systemic therapy and targeted therapy for male breast cancer are also the same as those for female breast cancer because most male breast cancers are also hormone receptor positive. Thank you so much for watching. Please subscribe and stay tuned for more educational videos.